So we are in an era of physiotherapy where we're seeing a lot more of slip discs or prolapsed discs in acute settings like physiotherapy clinics. Hi guys, welcome to Fun Facts Friday. Now, because people know that physios treat back pain and they don't need a direct ortho referral all the time, they do approach us even when they are in acute pain from a prolapsed intervertebral disc. If it is an acute to a subacute case, we know from a research as well as study perspective that they definitely need that initial rest period, activity modification, anti-inflammatory medications, and maybe some support in the form of a belt whilst that disc swelling settles. Once that initial phase is gone and we are in the phase 2 of starting some amount of physiotherapy intervention, we know what we need to look for is signs of not just pain relief but also reduction in neural sensitivity, reduction in the protective muscle spasm, and improvement in function. If I'm not seeing these signs, or alternatively, by about 3 weeks post their acute episode has started, if I'm seeing signs of some amount of foot drop or weakness through that lower lumbar and limb, if I'm seeing signs of the neural hypersensitivity not settling down after all that's been done in the form of rest and medication, and they're still not able to sit, stand, and walk without pain, I think it's time I tell them you need to pause and go see a spine specialist. Of course, investigations are also easy to get, and a lot of patients these days go for these investigations themselves, which is fine because it's going to give them much more clarity as to what path of treatment they need to take. But managing acute spine is an art. If you can't manage it, definitely please hand over your patient. And if you know you can manage it, be ethical and give them the right guidance right at the time when they need it.